Good morning to all. Today we are going to discuss about respiratory tract infection. Tract infection is the most common entry for infection. Then pathogens that enter the respiratory system can infect other parts of body and cause diseases. Then respiratory tract consists of upper respiratory tract and lower respiratory tract. Upper respiratory tract consists of nose, nasal cavity, sinus, throat, and associated structures such as middle ear, auditory tube. And lower respiratory tract consists of trachea, bronchi, bronchioles, and alveoli in lungs. Then classification of respiratory infection consists of upper respiratory tract infection include otitis media, common cold, sinusitis, pharyngitis, laryngitis, rhinitis, and epiglottitis. The most common infection involving the lower respiratory tract include bronchitis, bronchiolitis, and pneumonia. Upper respiratory tract infection. Infections may be caused in upper respiratory area caused by several bacteria and viruses. Sometimes it may occur as combination, that is by bacteria and viruses. Most non-specific upper respiratory tract infections are viral, not bacterial. Then some infections consist of otitis media, common cold, sinusitis, pharyngitis, laryngitis, rhinitis, and epiglottitis. So coming to otitis media is inflammation in middle ear. Its epidemiology says that otitis media is most common in infants and children, about 75% of whom have at least one episode by age of 1 year, and about 20% of otitis cases occur in adults, particularly in those with a history of these infections as a child. Then etiology include by bacteria, that is mainly due to Streptococcus pneumoniae, Haemophilus influenza, Streptococcus pyogenes, and Staphylococcus aureus. Then coming to the pathophysiology, acute otitis media follows a viral upper respiratory tract infection that causes the eustachian tube dysfunction and mucosal swelling in the middle ear. Then bacteria and virus that colonize the nasopharyngeal area thus enter the middle ear and not cleared properly by the mucociliary system. The presence of effusion, the bacteria proliferate and cause infections there. Then, as we all know, children are more susceptible to otitis media than adults because of the anatomy of their eustachian tube shorter and more horizontal. That will facilitate the bacterial entry into the middle ear. Coming to the risk factors, major risk factors are winter season, lack of breastfeeding in infants, Native of American or Inuit origin, early age of first diagnosis, nasopharyngeal colonization with middle ear pathogens, then genetic predisposition, if any siblings who are affected by this, then lower socioeconomic status, exposure to tobacco smoke, use of pacifier, male gender, immunodeficiency, allergy, and urban population. Coming to the clinical features, general features include onset of signs and symptoms of middle infection following cold symptoms of running nose, nasal congestion or cough. Then major signs and symptoms include pain that can be severe. There is more than 75% of patients showing pain. Then children may be irritable and have difficulty in sleeping. Then fever will be less, there will be less than 25% of patients experiencing fever. Then examination shows a discolored, thickened and bulging eardrum. Then pneumatic otoscopy or tympanometry demonstrate an immobile eardrum. 15% of cases are bilateral. Then draining of the middle ear fluid occurs that usually reveals the bacteria presence. Then coming to the laboratory test, gram stain can be done, culture and sensitivities of draining fluid or aspirated fluid if tympanocentesis is performed. Coming to the treatment goal, first goal is reduction in signs and symptoms, then eradication of the infection and prevention of complication. Then next is avoidance of unnecessary antibiotic prescribing is another goal in view of increasing problem of Staphylococcus pneumonia resistance. Then coming to the pharmacological treatment, treatment includes non-steroidal anti-inflammatory agents such as acetaminophen, ibuprofen can be used to relieve pain and malaise. Then antimicrobials can be included. Antimicrobial regimen to be given. The point antibiotics should be given after diagnosis require further evaluation. Generally, otitis media is treated empirically without laboratory test. Then acute otitis media should be distinguished from otitis media with effusion, presence of effusion. Then antimicrobials are indicated only for the former unless the effusion persists beyond 3 months in otitis media with effusion. Middle ear effusion in acute otitis media tends to continue after antimicrobial therapy is completed but does not require further treatment. Then amoxicillin is considered as a drug of choice regardless of the prevalence of drug-resistant staphylococcal pneumoniae. High dose of amoxicillin, that is 80 to 90 mg per kg per day, is recommended for drug-resistant staphylococcal pneumonia suspected. Then amoxicillin, clavulanate, cefuroxime, and intramuscular ceftriaxone and second-generation cephalosporin can also be used. Antibiotic prophylaxis of recurrent infection. If there is recurrent infection, recurrent otitis media is defined as at least 3 episodes in 6 months or at least 4 episodes in 12 months. Recurrent infections are of concern because patients younger than 3 years of age are at high risk of hearing loss and language and learning disabilities. So amoxicillin 20 mg per kg per day and sulfasalazole 75 mg per kg per day can be used. Then coming to the surgical treatment, surgical insertion of tympanostomy tubes, that is T tubes, is an effective method for prevention of recurrent otitis media. These T tubes, small tubes, are placed through the inferior portion of the tympanic membrane by under general anesthesia and aerate the middle ear. So, children with recurrent otitis who have more than 3 episodes in 6 months or 4 or more episodes in an year should be considered for the T tube placement. If children have experiencing severe nasal obstruction in addition to the recurrent otitis, adenoidectomy may be beneficial. Several vaccines are also available against that is influenza, pneumococcus may decrease the risk of acute otitis media, especially in those with recurrent episodes. So next is sinusitis. Sinusitis is an inflammation or infection of the paranasal sinus mucosa. The term rhinosinusitis is used by some specialists because sinusitis typically involves the nasal mucosa. The majority of these infections are of viral origin. Because of the viral origin, antimicrobials are frequently Antimicrobials are rarely prescribed. Thus important to differentiate between viral and bacterial sinusitis for optimizing treatment decision. Then viral sinusitis and bacterial sinusitis are difficult to differentiate because their clinical presentations are almost similar. Viral infections, however, tend to resolve by 7 to 10 days. Then persistence of symptoms may beyond this time likely indicates the bacterial infection. Bacterial sinusitis can be categorized into acute and chronic disease. That is, acute disease lasts for about 30 days with complete resolution of symptoms. Then chronic sinusitis is defined as episodes of inflammation lasting more than 3 months with persistence of respiratory symptoms. Coming to the pathophysiology of the sinusitis, similar to acute otitis media, acute sinusitis usually is preceded by a viral respiratory tract infection that causes mucosal inflammation. This can lead to obstruction in sinus ostia, the pathways that drain to the sinus. Then there will be mucus secretion became trapped and local defenses are impaired, and the bacteria from the adjacent surfaces began to proliferate there. These pathogenesis of chronic sinusitis uh, include whether it is caused by more persistent pathogens or there is a defect in any host immune function. Some patients develop chronic symptoms after their acute inflammation. Then coming to the signs and symptoms, Acute signs and symptoms in adults include nasal discharge or congestion, then maxillary tooth pain, facial or sinus pain that may radiate, as well as deterioration after initial improvement. Then severe, persistent or bacterial and treated with antimicrobials. In children, nasal discharge and cough for greater than 10 to 14 days or severe signs and symptoms which are temperature above 39 degrees Celsius or facial swelling or pain are indication of antimicrobial therapy. Then in the case of chronic, symptoms are similar to acute sinusitis but more non-specific rhinorrhea is associated with acute exacerbation. Then chronic unproductive cough, laryngitis and headache may occur. Chronic recurrent infection occur 3 to 4 times a year and are unresponsive to steam and decongestion. Coming to the goals of treatment, first is reduction in signs and symptoms, achieving and maintaining unobstructed ostia. Then another is next is limiting antimicrobial treatment to those who may benefit. Then eradication of bacterial infection with appropriate antimicrobial therapy. Next is minimizing the duration of illness and prevention of complication. Next is prevention and progression of acute disease to chronic disease. Coming to the treatment, approximately 40 to 60% of patients with acute sinusitis will recover spontaneously. When the decision to treat with antimicrobials is made, the choice must be effective, safe, and cost must be considered. Then amoxicillin will be the first line treatment for acute bacterial sinusitis. The drug of choice are first is amoxicillin. Adult dose will be 500 mg 3 times daily and pediatric dose of 40 to 50 mg per kg per day in 3 divided doses. High dose of 80 to 100 mg per day per kg per day divided in 3 divided doses. Then next drug is amoxicillin clavulanate 500 500 bar 125 mg 3 times daily and its pediatric doses 40 to 50 mg per kg per day divided in 3 divided doses and cefuroxime 20 to 50 to 500 mg twice daily and its pediatric doses 50 to 50 mg per kg per day divided in 2 doses. The cefaclo 250 to 500 mg 3 times daily. Its pediatric doses 20 mg per kg per day divided in 3 doses. Cefixime 200 to 400 mg twice daily. Its pediatric doses 8 mg per kg per day in one dose or divided in 2 doses. Then cefpodoxime 200 mg twice daily. Pediatric doses 10 mg per kg per day in 2 divided doses. Then trimethoprim sulfamethoxolone 160 bar 800 mg every 12 hours. Its pediatric doses 6 to 8 mg per kg per day trimethoprim and 30 to 40 mg per day per kg sulfamethoxolone divided in 2 doses. Then clindamycin 150 to 450 mg every 6 hours and in its pediatric doses 30 to 40 mg per kg per day divided in 3 doses. Then clarithromycin 250 to 250 to 500 mg twice daily. Its pediatric doses 15 mg per kg per day divided in 3 doses. Azithromycin 500 mg at day 1, then 250 mg per day into 4 days. Then its pediatric doses 10 mg per kg day 1, then 5 mg per kg per day into 4 days. Next is pharyngitis. Pharyngitis is an acute infection of oropharynx or nasopharynx, which results in 1 to 2% of all outpatient visits. While the viral causes are most common between group A beta hemolytic streptococcus or Staphylococcus pyogenes in primary bacterial cause. In pediatric population, group A streptococcus or strep throat causes 15 to 30% of cases of pharyngitis, while in adults it causes 5% to 15 of all symptomatic episodes of pharyngitis. To the etiology of pharyngitis, viral cause, that is by 20% rhinovirus, coronavirus of 5%, adenovirus of 5%, influenza virus of 2%, para-influenza virus of 2%, and Epstein-Barr virus of less than 1%. Then bacterial cause, group A streptococcus, that is 15 to 30%. Less common causes, group C and group G streptococcus, Corynebacterium diphtheriae, Neisseria gonorrhoeae, and Mycobacterium pneumoniae are some of them. Then coming to the pathophysiology, a breach in the pharyngeal mucosa allowing colonization of the bacteria and cause infection. Seasonal outbreaks occur in group A streptococcal pharyngitis is highest in winter and early spring. Then spread occurs via direct contact with droplets of saliva or nasal secretion, and transmission is thus worse in institutions, families, schools, and areas of crowding. Then coming to the clinical presentation of pharyngitis, general features include a sore throat of sudden onset that is mostly self-limited, fever and constitutional symptoms resolving in about 3 to 5 days. Clinical signs and symptoms are similar for virus causes as well as non-streptococcal bacterial causes. While other signs and symptoms include sore throat, pain or swelling, fever, headache, nausea, vomiting, abdominal pain, especially in children, then erythema or inflammation in tonsils and pharynx without patchy exudates, then enlarged tender lymph nodes, especially in throat area, then red swollen vulva, petachy on the soft palate, and uh, there will be a rashes. Then severe symptoms that are not suggestive of group A streptococcus are cough, conjunctivitis, coryza, and diarrhea. Then coming to the laboratory test of pharyngitis, throat swab and culture or rapid antigen detection testing should be done. Group A streptococcus positive test does not necessarily indicate disease. A positive test may indicate carriage. The low incidence of carriage in children is 5 to 20% and is considerably lower in adults. Then RADT is more practical and it gives results quickly. Then cultures are the gold standard, about 90% sensitivity, but require 24 to 48 hours for the result. Done if then newer RADT, rapid antigen test should be optical immunoassay and chemiluminescent DNA uh, tests are there. Then coming to the treatment, desired outcome, goal of treatment is to improve clinical signs and symptoms, minimize adverse drug reaction, prevent transmission to close contacts, prevent acute rheumatic fever and separative complications such as peritonsillar abscesses, cervical lymphadenitis, and mastoiditis. Pharmacological therapy includes supportive care including rest, fluids, lozenges, salt water gargle. Then symptoms may resolve 1 to 2 days sooner, which need some interventions. Coming to the treatment of pharyngitis, NSAID for pain. There will be pain, so NSAID is the first choice for pain. That is acetaminophen can be used. Penicillin is the drug of choice for the treatment of group A streptococcus pharyngitis. Then amoxicillin suspension in children. If it is penicillin allergic, use macrolide such as erythromycin or first generation cephalosporin, example cephalaxin. Newer macrolides such as azithromycin and clarithromycin are equally effective. Then penicillin resistant second generation cephalosporin such as cefuroxime and cefproxil can be used. Then third generation cephalosporin such as cefpodoxime and ceftenir can be used. Then macrolide resistant use clindamycin. New ketolides such as telithromycin may be used. For recurrent episodes, if there is recurrent episodes are there, use amoxicillin, clavulanate or clindamycin.